So I'm going to talk briefly in the beginning a little bit about how I got into public health and my career journey, but then I want to spend a fair amount of time talking a little bit about what public health is, because I think a lot of people don't necessarily understand what public health is, nor what opportunities there are for education and work and careers in public health. My journey to public health looked like this. It was not a straight path. It rarely actually is for most people in public health, and I think actually for most people in your generations, many times your careers are going to take a number of twists and turns. And a lot of that is, because when you're younger, you aren't even aware of some of the opportunities that are available to you. Also, when 95% of people who go to college change their majors, and it's because they get exposed to new opportunities. And so you end up doing that change. So I came to the University of Rochester in 1973, before most of the people in this room were born, I suspect. And for all intents and purposes, I have never left. As PJ indicated, I have my bachelor's, master's, and PhD in nursing all from here, which I'll go into briefly. But I'm not a Rochesterian. I was actually born in Ohio, but moved to upstate New York when I was 3. So I've grown up in upstate New York. And one of the interesting things about my career, and it actually was a factor in me coming to the University of Rochester, is that people have I've often had doors that have been opened to me, or opportunities that have been presented to me that I have pursued. So I remember, I graduated from high school in Ithaca, where Cornell is, and I remember sitting in the guidance office in the college catalog room. This is long before we had the internet, so when you were trying to find information about colleges, it was all paper-based. And a friend of mine said, "Oh, here, Ann, you should apply to the University of Rochester." And I did, among several other places. And I ended up landing here for a variety of different reasons. But I was a political science and economics major, a little bit different than what I'm doing now. But I had taken a year off between high school and college, had lived in Argentina, was quite interested in Latin American politics, and had pretty significant language skills in Spanish. But after about a year of courses, I'm like, I'm not certain that this is really what I want to do. And I spent my summer between my freshman and sophomore year of college working with some of my friends as nursing assistants in a nursing home. And I had never considered nursing. I'd never considered nursing because doctors yell at you. Why would you go into a profession where doctors yell at you? That was my level of understanding. But I got interested in it, and I'm like, well, geez, maybe you can go to college and become a nurse. That would be pretty cool. And I opened up my University of Rochester catalog, said, oh yeah, they have a nursing program. Little did I know that it was one of the top 10 nursing programs in the entire country. Again, I just happened to be there, happened to change, and that really changed my life entirely. So while this, again, looks like this nice organized path, underneath those arrows is really this kind of zigzag. Okay? So I got my bachelor's in nursing in 1977, and I'm reflecting back on that. Because the university is a research university, you really got very inculcated, I don't know if there's a sign for that, with research. And the importance of advanced education became very clear. And I was interviewed for a brochure that the School of Nursing was putting together. And in that interview, I was asked what I wanted to do, and I said, well, I'm going to get my PhD. Well, that was back in 1977, so I had that early in my mind. And right after I finished my bachelor's degree, while I started working in the hospital as a nurse, I started my master's degree. And it took me 3 years working part-time to get my master's degree. Now, what I was doing in my work was I was working in a hospital, and over time I worked in both the inpatient as well as the ambulatory part. I took on greater and greater administrative responsibilities because, frankly, patient care was boring. You know, I wanted to do kind of bigger things. Of course, I had been organizing events since I was probably 5 years old. You know, I was the organizer, the person who did the parties, the person who, you know, got everybody, you know, together to do something. And so have been an organizer, and I just think the administrative part of that, you know, was fit my interests or my skills. And I worked, I got my master's degree in nursing. I worked with women who had cancer. So this is women who had cervical cancer or ovarian cancer, and got involved with the OBGYN department, so obstetrics and gynecology, because that's where women who had cancer. But that was also the same department in which women had babies. So I ended up over time shifting from being very focused on kind of women's health and cancer to being focused more on, or more broadly, on maternal health, and as a result also on the health of infants and young children. I got my PhD in 1996. It took me 11 years to get my PhD, longer than most people take, because I was doing it part-time, because I worked full-time during my entire PhD program. While I was getting my PhD, I changed jobs twice. We moved, and I had a baby. Life gets in the way, so it took 11 years. But in the time when I was working in my administrative role, I started getting involved with some research. And my research was out of an interest I had in patient satisfaction. What is it that helps, what makes people satisfied with their experience in the healthcare system? And I was focused on the hospital part of it. And what was interesting is that people would come in and have these wonderful birth experiences and complain about the food. Because they had a wonderful, or excuse me, they had a wonderful birth experience, or they had a bad outcome and their child was in the NICU, so the kid was sick, born prematurely or whatever. Those parents wouldn't complain about the food because they didn't care about the food and the parking, they cared about the care. But if everything went smoothly and you had this lovely delivery and this healthy baby, you complained about the food and the housekeeping and the parking. So I was trying to understand what was the phenomena that contributed to people being satisfied. So that led me into interest in developing a tool to measure patient satisfaction, and I got involved with a research project that was studying different forms of nursing care. And I designed a tool, and we tested it, and it was published, and I, to this day, get people asking me for if they have permission to use the tool that we developed, and that was back in the late 1980s. But that got my foot into the research door while I was still working on my PhD. And then my PhD was on the nurse-patient interaction, because from a satisfaction standpoint, my question was, what was it about the nurse-patient interaction that made a difference to the experience of care that these women had? So I got through that, and I got my PhD. Phew. It is the most grueling thing I have ever done in my life. To this day, I say that. Yeah, disagree with me. And I remember I was due to defend my dissertation on a Friday. Mind you, I'm still working full-time. I remember on a Tuesday of that week driving to work with my hands gripping the steering wheel, and I'm thinking, this must feel like what it's like right before you're going to have a stroke, because I was so wound up like a cord. I mean, my job's making me crazy. I've got this rather important presentation that's coming up on Friday, and I was just, anyway, I lived through my dissertation. While it was the most grueling thing, it was the best thing I did, because it opened a lot of doors. Because this transition here between leaving the hospital and going into research was because there was a reorganization at the hospital, and suddenly I did not have a job. And at the time, I thought I would only ever want to work in a hospital. But the more I did some analysis of that, and the more I talked to people, I realized that I had other things that I wanted to do. And in that interim time, I had the opportunity to work at a community-based organization. Again, an opportunity that presented itself. Literally a colleague of mine called me up and said, and my project director for this federal program just left. I need somebody to step in for a few months and help us kind of keep things going while we hire a new person. I'm like, sure, great. I'm in. And I did that. And what that opened up for me was a whole area of work in public health, as it turns out, and working with community-based organizations that when you're in the hospital, you don't see. I mean, you kind of understand it's out there, but you think you're the center of the universe when you're in the hospital. And the reality is, you're not. But, you know, it all depends on your perspective. So not only did I have a chance to work with people in maternal child health who were out in the community working with women who were pregnant, getting ready to deliver, or after they had delivered and now having to cope with the newborn. I also, because this was a federally funded project, it had an evaluator. The evaluator was a faculty member from the University of Rochester, who I'd never met at the time, who said, when you're done with this, come back and work with me. Again, door open. I said, oh, hey, that'd be cool. So I did that. Changed my life. That was Tim Dye, by the way.
Oh, really?
Yeah, so this is a colleague who's now back working with us. But so I came back into the university, but now I was not on the hospital side. I was on the academic and education side. And not in the School of Nursing, but in the School of Medicine. And the department, while it's now called Public Health Sciences, at that point it was called Community Preventive Medicine. So I continued with my work with maternal child health, and I then became the evaluator for that project that I had been involved with, that I was the project director of. I'm on the university side of it. I'm now participating in the evaluation. And I have continued my involvement with that. So I shifted over in 1999. I am still involved with that project today. I also got involved with program evaluation. So that's kind of figuring out if programs work. You know, once we want to figure out, we know how to help people stop smoking. How do we implement it and get it scaled up or disseminated or get all the providers to do the right things? How can we take interventions that we know work and get everybody to do them? It's like, we know seatbelts work. How do we get people to use seatbelts? We know vaccines work. How do we get people to want to get vaccinated? So my program evaluation work, I got some initial funding through a New York State contract where I trained people out in the community, so community-based organizations, how to do program evaluation. I trained people at the New York State Health Department how to do it. I converted my training into a course that we still offer today in our graduate program. And then I got brought into other people's grants who needed an evaluator because they were doing what we call dissemination and implementation. So when we think about the research continuum, there's basic science work that you've heard of, cells, molecules, animals, gets into kind of human research, and then you figure out what works and you want to get it out into practice or out into the community. And that is dissemination and implementation, and that needs to be evaluated. Is the implementation being done with what we call fidelity? Is it being done kind of by the book about how it's supposed to be? Are we having the same effect that we had in the original study work? So I've gotten involved with that. So I've been involved with then evaluation of some other people's projects. And then I've been involved with evaluation of what we call infrastructure projects. Infrastructure projects means that they're where you bring resources in to build what we call capacity. So many of you are familiar with NCDHR. I was the first evaluator for NCDHR. I had to give that up when I got some additional funding. You are maybe familiar with our Clinical Translational Science Institute. I'm the evaluator for that. I'm also the evaluator for our Center for AIDS Research. So this idea of program evaluation, which actually started in my clinical time, because I was interested, not in patient care, but I was interested in how systems all work together and how people work together and how change happened. That I really continued into my research interests. The other part of program evaluation happened when I got involved with a project that was first funded by the CDC. And again, things happen. And I should comment back on my first New York State contract. It's because a colleague across the hall said to me, Ann, I'd like to apply for this funding, but I really don't have the time. I think you should do it. So I wrote the grant and got the funding. I mean, it was, again, things just happen. And part of it is also not just because people were offering me opportunities, but because I was open to receiving those suggestions. I didn't try to pigeon myself, hold myself into saying, I only do this. I was open to other things. It's also a way to make yourself crazy, because right now I'm on 9 projects, but we won't talk about that. But similarly, the CDC-funded evaluation was in maternal child health, but it was all about breastfeeding. Now, if somebody would have told me 15 years ago that I was going to study breastfeeding, I would have told them they were out of their minds, because I had no interest in studying breastfeeding, despite the fact that one of the most prominent researchers in breastfeeding is actually at the University of Rochester. But I didn't have any interest in that. But I had a student who was interested in breastfeeding, and I was interested in program evaluation of the implementation of programs. And that's what these grants were about. So I applied, and I got funded. Not once, not twice, but 3 different times, all about breastfeeding and all about program evaluation. And it's because my students said, Ann, we really should, we could do this. I'm like, okay. So we did. And then that created enough of a basis that I could apply for some NIH, or National Institutes of Health funding, and I did. And it was what we call an R01, so this is one of the big 5-year, $500,000 a year grants. And this particular funding opportunity was open for a 3-year period of time, but you only had one time each year to apply. So I was in the 2nd year of the funding opportunity, and I applied saying, okay, I'll get feedback so then I can apply the next year. Well, I got such an outstanding score on that first application that I got funded with my first submission. Very unusual, particularly for the first time you've ever done an R01. But some of the reason that I was successful is that I had had all these partnerships that had been created through the CDC grant, and because I'd been working in this community for a while. So I could literally write in this grant, because I had to identify some partners. I could say, I have worked with this partner for 10 years. So it wasn't I called them up and they sent me a letter of support, but I've never seen or worked with them before. It's like, no, we had a working relationship. So I was able to leverage some of this work, and that's what helped me be successful with my initial R01. And I've since gotten another 5 years of funding, so I'm in actually year 8 of this project, again, based in program evaluation and dissemination. And what we're looking at is we're looking to we work with hospitals, prenatal care sites, so where women go to get their care while they're pregnant. We work with WIC, which is the Women's, Infant, and Children's Supplemental Nutrition Program, because they do breastfeeding peer counseling. So I'm working with these different agencies and with pediatricians' offices to get everyone to increase the number of practices that they are doing that shows evidence that they support breastfeeding. So the focus is on low-income women, and my question and my researching is, because all of these evidence-based practices have been studied in isolation. So we've studied breastfeeding peer counselors, we've studied hospital practices, we've studied prenatal practices, but we haven't studied them implemented at the same time across the community to see what we can do to increase those rates, what works synergistically, et cetera. So that's kind of where the research part of this comes from. But it's all at that dissemination and implementation rate. I am not trying to study whether if you do X, you're going to increase breastfeeding support. I already know what to do. It's getting the different organizations and institutions and providers to do that on a consistent basis. So that's kind of where I've gotten in terms of some of my maternal child health work. I do qualitative and quantitative work. So I don't just work with numbers. We interview women, families, providers to understand what's going on, and so we have that whole piece of the analysis. Jessica, where is she? Jessica and I have an article together that she worked on with Nancy Chin. That's all that uses qualitative methods for that. And then I also had the opportunity to do some international work, which has been very fulfilling as well. I've had the opportunity to be in Tibet, the Dominican Republic, Costa Rica, Grenada, India, and as well as Antarctica, of all places. So, Yeah, the only continent I have not been to is Africa, and I have a conference I'm going to in March, so I'll be able to check off that as my 7th continent. So, yay! So anyway, so that's kind of my story of my career. And I've kind of, as you can see, because I'm now the chair again, I've not let the administrative stuff go. I actually had a hard time being a faculty member and not being involved with the decision making because I wanted to contribute to that part of the work. So if we look at the continuum, and this goes for almost all science, you know, it's understanding the problem, what works, and then from an implementation standpoint, implementing what works. Okay? So there's a lot of things that affect our daily lives that we don't even think about being part of public health. So I was in India a few months ago. One of the things I can't do in India is turn on the tap water and drink the water that comes out of the tap, or I would get sick. Clean water is public health. Vaccinations are public health. So the immunizations we give to kids, the yearly flu shot that I'm hoping you all got, you don't have to tell me. It's public health. Things like fire safety, putting fire retardant on clothes and pajamas to reduce, you know, deaths from fires. All the environmental regulations. So all this stuff that's going on about climate change, it's all about public health. Pollution controls, public health. Even things like sanitation. How do we manage our garbage? Keeping rodents out of our food supply? The inspections that happen in workplaces or in restaurants, that's all about public health. Guns, yes. Yeah, big issue. Mm-hmm. Understanding the problem, we need data. Understanding what works, we test solutions. And then implementing what works ends up being policies, products or changes in products, and education. I'm going to walk through some data just so that you have a feel for what this was. So when I grew up, the front page of the paper, after every Thanksgiving and Christmas holiday and other major things, one of the main articles was how many people died on the roads. You don't see that anymore. And it's not that nobody's dying, because there are, and but so back in 1965, across our country, over 700 people were killed in traffic accidents. In a non-holiday period, so this is like the Wednesday through Sunday period, only 540. So 200 more people died during the holidays. Now, some of that's because there are more people on the road. You could argue lots of different reasons. But this kind of thing, we don't talk about this anymore. But this is what's happened. And this is per million vehicle miles traveled, per 100 million vehicles miles traveled. So that's like a lot. That's like thousands of times around the Earth. But you'll notice that we have the same number of people dying, but the rate based on how many miles traveled has gone from 7 people per 100,000 down to about 1. That is a huge, and this is from 1950 to current day. That's a dramatic decline. And maybe this doesn't seem, but when you look at this for how many more people are on the road, how many more cars are on the road, how many more miles are being traveled, it is huge. Because you've not changed the numerator. We've changed the denominator big, but we've not changed this numerator. And there's a reason for that, which we'll talk about. And this is deaths per 100,000 population. So we used to have about 23 and then up into 27 deaths per 100,000 people every year. That has fallen down to 10. Again, this is an incredible public health success story that people have been working on, obviously, for many, many years. So what is this success due to? And some of you would be able to probably answer some of these. So it happens at a lot of different levels. So there's things that happen at the level of the individual. And some of these are because of policies. And what's interesting about public health is we can do a lot of work with specifically individuals, but oftentimes it's the policy changes that have the largest effect. So we have policies that people actually have to get a license to drive. Years ago, that didn't happen, or it didn't happen in every state. We have limitations on teenagers, right? What age can you get a license, but also, you know, what kind, you can have a graduated license, you can't be, there are other restrictions for teens. We have training. We have this whole issue of being a safe driver, not driving when you're sleeping, not texting where you drive. That was not a problem back when I was growing up. Drinking while driving. But mind you, while we have policies that say not to do that, this ends up being an individual decision. You make a decision to get into the car and drive. And you make the decision about whether you are safe. But these things are enforced. There's penalties if you don't. And then there's seat belts and car seats. Again, individual decisions. So my husband is an old car buff. We own a 1962 Chevy Impala convertible. It's a gorgeous car. Seat belts were optional in 1962. And when you could get them put in, they were only available in the front seat for the driver and one passenger. That was it. So seatbelt use has become, seatbelt availability in the car is a change to the vehicle, but for it to work requires the individual to use a seatbelt. Equally for car seats. You have to have a car seat, and you have to put your kid in the car seat for it to work. But so we talk about vehicle safety. So now we've talked about beyond the individual. What have we changed about the car? So the car has huge changes. It used to be, so the 62 Chevy Impala convertible is made like a tank. It is metal. The dashboard is metal. It was meant to be, if you were in an accident, you would win. You would beat the other guy. What people realized, and why they've made these into collapsible materials, is that now when you hit somebody, your car crushes to absorb that energy. Because when you were in a tank, when you were driving a car that was like a tank, and you hit something, where did that energy get transferred? Into the passengers, and so the passengers got thrown out of the car because there were no seat belts. So you've got collapsible materials, seat belts, airbags. Airbags are passive. You don't have to turn them on and off. They're going to work whether you're in the car, you know, regardless of what you do. So they are a type of what we call passive restraint. It protects you, but despite yourself. You know, you don't have to do anything. We also have emergency flashers. You know, the little button you press that your car flashes. Those didn't, when I was learning to drive, those didn't exist. But that's how you don't get your car hit when you pull off the side of the road or if you're going slowly. You've got headlights. The quality of tires has changed. There are required inspections of your vehicle. Again, all these things are contributing to adding to safety. For pedestrians, we've got sidewalks, signals, and many of you may be aware, so New York State and other states have this law about needing to stop if there's a pedestrian in the sidewalk or in the crosswalk. Not all states have that. But those are things that reduce, because vehicular-related deaths aren't just to people in the car. They can be to pedestrians as well. Then there's things we've done to the road. Again, doesn't require the driver to do anything different. It's changes in what's being used for the road that reduces the chance that you're going to like hydroplane when you hit water. We put guardrails in there. In fact, I heard a piece on NPR over the weekend. They talked about, why were guardrails invented? So guardrails are what's between the two streets or on the side. And they were primarily invented to stop head-on crashes. And they have significantly reduced head-on crashes. You've got rumble strips, when you veer off the road a little bit, it wakes you up to make you realize you've veered off. You've got cat's eyes, there's speed limits, there's enforcement, and then there's road treatment. So here we get salt on our roads. So anyway, my point is that reduction happened over time because not just of one thing, but because of multiple of changes in a number of different policies that both affect the individual and affect the product or the thing that the person is using, the car, as well as the environment in which the car is being driven. And that really represents a lot of what public health is all about. Yeah?
What about animals?
So there are, in terms of animals across the road?
Yes.
Okay. So there are places in which they've put up barriers to reduce. So if you drive down the thruway and you look there's fencing on the sides so that it doesn't mean that they don't get across, but they do things to reduce that, absolutely. And that's a great question. And, any of us who are driving around here, right around now, you got a lot of deer on the road, and there's only so much we can do to keep the deer off the road. Unfortunately, during mating season and during hunting season, they are all over. So one of the models that we think, or the way we conceive about public health, are something that's called the social ecological model. And it actually informs almost all the work I and many of my colleagues do. And it helps understand why, if we implement something, why it might work or might not work. So the point of it is that all of these levels interact. And if you want to make progress on a particular public health issue, whether it's gun control, smoking, other risk factors like HIV, there needs to be activity going on in each of these areas that is kind of reinforcing. So I'll give you an example of a non-reinforcing thing. So I think that we want to have kids not be overweight. So we talk to parents about feeding them more fruits and vegetables, get kids interested in fruits and vegetables, change what's available in the schools, so we get out the sugar-sweetened drinks and we have healthier menus. But then we have places like McDonald's and other places that promote, the supersize this, the fatty whatever. And so that's where some of what's going on in the environment is a counter effect to all the other things that you're trying to do. It's also one of the reasons why McDonald's and some of these companies are starting to try to maybe have their food be a little bit healthier. Anyway, so when you look at people, we want to change people's behavior, which is when we're talking about public health. We talked about preventing disease. We talked about, healthy behaviors. So part of it starts at what's going on in the individual. What do they think? What do they believe works? What are some of their genetics? Are they predisposed to a particular condition? What are their current, behaviors that they have? So when I look at breastfeeding, I think about, does this mother believe that it's important to breastfeed her child? Has she had any experience breastfeeding? What's her confidence, with that? And then when we get to the interpersonal, these are people that are around her. What does her spouse or the father of the baby think? What does her mother think? What does her friends and her sisters think? What do her coworkers think? Because they all influence whether she's going to breastfeed, or if she starts breastfeeding, she's going to sustain it. Then you get in the community, what are the norms? Are people expected to breastfeed? You go down into the Caribbean, everybody breastfeeds. It's not even a question. Here, it's a big issue. And I had a young woman I was interviewing. This is her second child. Her husband was from the Caribbean. And so, you know, she was breastfeeding here and doing very nice. But about 5 months in, they took the child to the Caribbean to meet the grandparents and the other family. And I said, so what was it like to breastfeed there? And she said, so I'm breastfeeding and I'm covered up. And then these women are like going, what's that blanket on there? Take that off. You know, because down there, you didn't need to cover up. It was considered totally normal to breastfeed in public in a way that you know, you didn't have to cover up your breast. So I asked her what that was like, and she says, it was like liberating. It was a totally different cultural experience where people didn't kind of look at you odd that you were breastfeeding. It was like they would look at you odd if you weren't. But it gives you a flavor of kind of what are the community norms and standards. If we think about the gun control example, we've got huge issues about what community norms and standards are for what people think is acceptable or not. Then you've got institutions. So from a breastfeeding standpoint, it's what are the practices that are going on at the hospital? What are the things that are being said or done at my doctor's office? What happens when I go back to work? What kind of support do I get there, if any, or if I'm back at school? You know, what kind of support do I have that I'm a breastfeeding mother, et cetera? And then you've got larger structures and policies. So again, from a breastfeeding standpoint, it's do they allow breastfeeding in public? What is the finance? What insurance coverage is required for breastfeeding? What kind of requirements are there for provider practices? What kind of what do they allow in terms of like formula marketing? So in many other countries, you can't market formula. Here, you know, you see ads for Similac and Enfamil and all that. In other countries, that's not even allowed. So, but that's all policy related. And then what's not depicted here is more of the environmental impact, which is the air you breathe, the water you drink, you know, what's in your larger environment in terms of exposures. Because we talk about, in public health, we talk about exposures. Some of those are things we control. Some of those things are we don't control. The ones we do control are things like, you know, do we smoke? Do we eat right? Do we get enough sleep? Do we put a seatbelt on? Those kinds of things. We also talk about risk factors and protective factors. Those are other terms we use. So risk factors are things like that we may have risk factors that we have no control over. Risk factors because of what the family that we were born into. Risk factors because if you're a certain age, you're more at risk for certain conditions. Certain races and ethnicities have more risk. Men have a different kind of risk than women do in different diseases and conditions. So you have risk factors. Some of those aren't modifiable, you know. People with lower education are at higher risk for health problems. So as I said, some of them are modifiable and some of them aren't. I can't change the family I was born into. I can't change my race. I can't immediately change my education. Over time, I can. In fact, one of the things that they've shown in many developing countries is the best way to improve the health of the population is to make certain that young girls go to school and get at least to the 6th grade, because it has such a dramatic impact on the health, not only of her, but of her entire family, because she makes better decisions about the health and safety of her family. So this is just a list of a whole bunch of different kinds of public health areas. And you know, the neat part about public health is that it is hugely diverse. And you can do a lot of different kinds of things. And I'll walk quickly through what some of these are. And you've probably heard, you know, many of those terms. So when there's an outbreak, you've heard about measles outbreak. Some of you may remember the SARS outbreak. We talk about avian flu, the H1N1, which was the big virus that happened several years ago around the flu. Epidemiologists study disease. One of the things they study is disease outbreaks to try to figure out, how did that start? Some of the conditions that you get into with when there's food poisoning, they want to figure out kind of what's causing people to get sick. Was it the tomatoes or the lettuce or the salmonella on the eggs? But they want to figure that out. So they do field work as well as a lot of data analytic work. And they want to look at also the association of what we call demographic, which is like, age, race, place, and social trends that can contribute to disease and injury. So it's a very data-oriented profession. They do some qualitative work, although that's not the main part of their training. They oftentimes actually partner with some of the folk like me to do those studies together. So they use statistical analysis and as well as other sciences. So it isn't they don't just work by themselves. They partner with a number of other scientists, and they look at issues, as I said, like heredity. So one of the big new areas that's been emerging in the past 10 plus years is what we call epigenetics. So we used to have this funky argument that was nature versus nurture. People behave like they are because that's how they were born. And then there were people on the other side of the camp that says, no, people behave why they are because this is how they were raised. Well, nothing's ever that black and white, thank you very much. But people couldn't figure out how to connect those two things into a coherent understanding of human development. Epigenetics has begun to help us understand that because we have a certain amount of genes that we inherit, but whether those genes turn on or turn off is often because of what we were exposed to when we were fetuses or when we were young children. And when I say exposed to, it can be an environmental exposure. It can be whether we were given adequate nutrition. It can be whether our mother smoked or took drugs during pregnancy. It can also be around breastfeeding actually affects the epigenetics. And there are other exposures that you get over time, and that's, as I said, it turns genes off and turns gene on. And then what happens is that you then share that change with your offspring, which means, and that's how some of these changes cross generations. But that's one of the newer areas of study within epidemiology. Behavioral science, which is a little closer to the area that I work in. Again, encouraging people to make healthy choices or avoid risky ones. So making healthy choices is what we consider a protective factor. I exercise. I don't eat too much fat. I get enough sleep at night, as opposed to drinking and smoking and having unprotected sex and those kinds of things, or living in an environment that's very polluted, for example. So some of the kinds of things you talk about that you would do within behavioral sciences and public health, so stop the spread of sexually transmitted diseases. So some of the work with the vaccines like HPV, I don't know how many of you know, but so HPV is a vaccine to prevent cancer. When I was growing up, we didn't understand that that viruses could actually cause cancer. Recognize and avoid the dangers of unprotected sex or drug use, reduce obesity, and then it's when it says it's related problems. So you get overweight, you tax your organs, and you contribute to diabetes and all kinds of other problems. Again, there's quality of life issues. You can focus on improving the quality of life for seniors. These are just some examples of how behavioral science, in the context of public health, what kinds of things one might work on. So you want to look at developing new programs to promote health, such as reducing smoking. There's water projects. There's occupational safety, so safety in the workplace. And then it's this whole other issue of complex health issues, because things are not, just like we saw in that the diagram with the individual and the interpersonal, nothing is ever kind of single causal. It's got multiple parts to it. So kind of understanding how, what is the part that the individual contributes versus what are the factors in the society or the community or other things around there to make that, to help that person be more healthy. Biostatistics is actually another arm of public health. Now, not all biostatisticians work in public health, but they do contribute to analysis of our interventions to help us figure out what is and isn't working. They look at trends in communities, risk factors. They dig into some of the more biologic phenomena of what's going on. You typically use biostatisticians when you're doing what we call clinical trials or very, kind of complex research studies. Environmental health, a major area, and I've mentioned a couple of examples so far. There's, again, a lot of interactions between the environment we live in and our health. In fact, at the university, in my department, we have a core group of faculty who do environmental health work. One of them did a very interesting study with colleagues in China. So the Olympics were there several years ago. And one of the big issues in Beijing was how lousy the air was. And so they made huge efforts to improve the air quality during the Olympics. And so these colleagues studied women who gave birth and who were pregnant before they improved the air quality and after they improved the air quality to see if their birth outcomes were any better. And they, in fact, found that women who had given birth or who had the last month or so of their pregnancy around the time when they were improving the air, their babies were bigger than the women who were exposed, than the women who breathed the air that was polluted. So it's a really interesting connection. You to think about, so you're breathing polluted air and your baby's going to be growing at a different rate? Wow. I mean, that's pretty remarkable. It also shows you how bad the air pollution was with it. But it's just an example of all the different ways in which the environment can have an impact on health. Many of them, some of them are kind of obvious. I mean, you drink lousy water, you get sick. But the impact of breathing poor air or of living in an environment where the water may, so this is the whole issue of fracking that you may or may not have heard about in the news. So this is so Pennsylvania allows it, New York State doesn't. And the issue is what's happening to the water there, and is there a connection then to the health of the populace? One of my colleagues is actually just got funded to do some studies of births in Pennsylvania in areas where there's fracking and areas where there's not fracking, to be able to help document the extent to which not only are there birth changes, but she's also connecting the data to educational performance to see if the children born then actually have cognitive issues later on in life. That's a little scary. Again, it's wide-ranging and it's a complex profession. You work with a lot of other people, not just in the healthcare field, but also chemists and geologists. It's really quite a remarkable and growing field. And then there's Health Services Administration. You can, learn to manage public health programs or public health agencies in health departments at the local, state, national level. So there's a whole administrative area of public health as well. There's some other areas that are less prominent in public health, but are kind of subspecialties. One of them is laboratory medicine. So this is where you get into looking at bacteria and and viruses. You also get into screening for what we call metabolic disorders. So one of the things, there's certain conditions that we can diagnose at birth that if we can treat really early, the child will not suffer from that. Or if we find out early enough, we can manage it so the child doesn't have all of the symptoms. Maternal child health, we've heard several of my stories about maternal child health, but it is one of the reasons that it is so important is because so much of the health of the adult starts when you're a fetus, or starts even from how healthy your mother is. One of the interesting statistics is if you are, my risk for delivering a baby prematurely is partially whether I was born premature by my mother. So if I want to change the premature, if I want to improve the premature birth rate among women giving birth now, I needed to change the prematurity rate among their mothers 25 years ago. Now that's not going to solve all the problem, but the fact that there's a connection there, it's kind of scary because it's like, what we can and can't control becomes challenging to figure out. The other thing that we've discovered in maternal child health is we used to say, oh, this woman is pregnant, we got to make certain she's eating right and doing all these good things during pregnancy. And then we would be surprised that some people still had bad outcomes. So then we realized, well, that was kind of, not very, we weren't thinking very clearly, because why would we think that in a short period of time, now pregnancy's 9 months, by the time she comes in for her first appointment, she's at least a month pregnant. Sometimes they deliver a little early. So you've got this 6 or 7 month period of time in which you can work with it. Why would we think that in 6 or 7 months we could turn around a lifetime of deprivation, of not eating well, of smoking, of whatever? So now we've transformed into a life course thinking. So let's get people eating right and treating their bodies right before they get pregnant. Or just as importantly, if they're not doing that, let's get some effective birth control going on so that the woman whose body isn't ready for pregnancy doesn't get pregnant. So we're taking this life course approach, and so we work with women before pregnancy and between pregnancies, not just during that brief period of time. And that's been one of the interesting ahas in maternal child health. It's a big, what we call paradigm shift. So it's kind of a philosophical shift away from just focusing on the pregnancy. Looking at changes in the diet, such as reducing salt intake, all of those things are aspects of public health nutrition. And then there's occupational health and safety, which we don't really tend to think about that as public health, but it's the safety of the workplace. It's designing machines that people work with or areas that they work to be safe. It's the little signs that get put up when the person has mopped the floor so people don't fall. It's how stairs are designed. It's how there are vents in particular ways that air is handled in places where there are toxic fumes, for example. So it's a lot of different safety issues that are all about public health, but it's in the context of the health of the employee. And then obviously there's an aspect of this that's also safety inspections to make certain that people are adhering to the safety. So even things like the placement of fire extinguishers and training about how to use fire extinguishers, that's all about public health. We don't think about it that way, but it is. Summary slide that really talks about just public health. So we're promoting and protecting the health. We talk about primary and secondary and tertiary prevention. So primary prevention is preventing people from getting sick to begin with, so they don't have to go to the doctor. Secondary prevention is when someone's sick, preventing them from getting sicker or getting more side effects. And then tertiary prevention is when people have gotten the side effects and helping them manage those. And again, it's promoting wellness by encouraging healthy behaviors. So what I'm going to challenge you, that I'm a member of the American Public Health Association. And if you're interested in more information about public health, this is one of the places to go to. The American Public Health Association, or the CDC, the Centers for Disease Control, has more information about public health and careers. So they've started an initiative called the Generation Public Health, and they're asking, they've just started this initiative in the last month. They're asking people to sign the pledge to be healthy, so that we, over the course of the next generation, can be the healthiest generation. So I would encourage you to consider taking the pledge to sign up to be a member of the Generation of Public Health. It's very easy to do that. All you do is say, if you type into Google Generation Public Health, you will get to that website. So I would encourage any and all of you to do that. And that kind of ends my formal remarks. Thank you.